All right, so welcome everyone. Thank you so much for joining us today after a brief hiatus back to the Nerve series. Today, we're really fortunate to be joined by Dr. Teddy McRackan, who's an Associate Professor of Otolaryngology here at MUSC, where he also serves as the Director of the Skull-Based Center and the Medical Director of the Cochlear Implant Program. Dr. McRackan's originally from Virginia. He did his medical training at MUSC, followed by his otolaryngology residency at Vanderbilt, and then a fellowship at the House Ear Clinic in LA. His research focuses on the development and application of novel measures to evaluate outcomes in individuals with hearing loss and cochlear implants. And in particular, his work is focused on using patient-reported outcomes measures such as the CIQOL and the CIQOL expectations instruments to better understand how patients are really benefiting from our interventions as providers, towards the goal of improving counseling, better predicting results, and helping patients to better develop and understand reasonable expectations. Among his many accomplishments and accolades include funding from the NIH. He received the 2022 Harris Mosier Award, and he has a very impressive body of published work, some of which we'll likely be speaking about today. So we're very lucky to have Dr. McRackan here to talk to us today. He'll be sharing his talk entitled, "What Do We Really Know About Adult Cochlear Implant Outcomes?" and how I learned to stop focusing on speech recognition scores and love patient-reported outcome measures. So thank you very much, Dr. McRackan. I'll hand it over to you.
All right. Thank you, Josh, for that introduction. Excellent. Yeah, so kind of this is a little bit of it's our research, obviously, kind of integrated into this, and it's a reference to Dr. Strangelove is the title there. But it's kind of an understanding of how we measure patient outcomes, how we what do we actually focus on when we make clinical decisions, and kind of how our outcome measures are involved in that. So just real quick disclosures, and I don't know, Josh, if you want to do questions people ask out loud, or do you want people to chat? What do you prefer?
Usually at the end, we can do questions, and you can feel free to put the questions in the chat and I can read them out loud. Or if you prefer to raise your hand, I can, you can just unmute yourself and ask them. I'll usually start with a question or two and then let others jump in. And just so everyone knows, we do record and transcribe this lecture today and on the other so that we can post them on our YouTube channel later. So just so everyone's aware that we are recording the session today.
Great. So I am on the advisory board for Envoy Medical, and our funding for this and of our work has come from the American Cochlear Implant Alliance and the NIH and NICD. And one of my biggest disclosures is that I am not a psychometrician. I have a working level knowledge of all psychometrics and all things instrument development, but I have many wonderful colleagues who've kind of helped along the way. So kind of when we talk about patient outcomes and what we're measuring in clinic and in labs and things like that, the question arises kind of what actually is an outcome measure? And this is something that's fairly well defined kind of in the measurement science, right? So not every score or every count that we get is an actual outcome measure. It needs to assess a kind of a pre-identified latent trait or a particular construct, right? So a ruler measures size, a thermometer measures temperature, a scale measures weight. And it's really important kind of as you apply these measures to have a clear understanding of what you're able to measure with the instrument that you're using. So an example is, let's say you want to measure danger, right? And you're in a cave, and the question is you're surrounded by 6 bears or 1 bear. Right? And which situation is more dangerous, right? And I think the knee-jerk reaction is to say the 6 bears. But like, what if I told you that 6 of the bears were sleeping, right? Or in a deep, deep hibernation, and one of them just woke up from hibernation and hadn't slept, hadn't eaten in months, right? So obviously that 1 bear in that situation is more dangerous. So really the context and kind of understanding what you're measuring and the nuances are really important in the situation. So what is kind of the ideal outcome measure? The ideal outcome measure is a ruler. It's kind of a perfect example for an outcome measure. It identifies a latent trait, right? Length, right? There's no question what you're actually measuring when you're using a ruler. It is standardized, so you don't take a pencil and you put it in the middle of a ruler and say that, okay, that's how I'm going to measure. I'm going to measure 13 minus 4 to get the measurement. No, you start at 0 and you go up on the scale. It is sample free, so it doesn't matter what size pencil you're measuring. You can measure any size pencil with a ruler, right? It's test free, so there's many different kinds of rulers out there. You can use, yardsticks, measuring rods, and little micrometers as well, right? So when you're measuring using these things, the efficiency might be affected, and the degree of error associated with using each of these essentially rulers does change. But overall, you're going to get a very similar answer with no matter what kind of ruler you're using. It's efficient, right? You put it at 0, you measure up, go from there. It's precise, right? You can measure the same pencil using 3 different rulers and get very similar outcome measures, okay? So the question arises, and that's kind of sort of down this trail, is do our current outcome measures meet these criteria, right? And particularly talking about speech recognition scores and speech recognition testing, are we using what's considered an adequate outcome measure, the measure of the outcomes for adult cochlear implant users? And so this is the basic question that we're going to talk about today is what do we know about outcomes in adults with cochlear implants? And more granular, like the patient comes to see you in your clinic, right, for an implant evaluation. What can you actually tell patients about how they might perform with their cochlear implant? So, this is during a speech, during this cochlear implant evaluation process, you can talk to patients about a few things, right? You can talk to patients about speech recognition improvements. We have data on that. We can talk about real world functional abilities. But really our current standard is the audio booth, right? It's what is performed in the booth. What's their words recognition ability? What's their sentence recognition ability? Quiet and noise, and there's many different ways to do this. But these are data. Let me see here. Is this the laser pointer? Can you see that? Yeah, good. So here we see, this is data from a meta-analysis we do, and this is several, hundreds of patients who've been published in the literature. And we see, right, words in quiet, there's, dramatic improvement from pre to post, sentences in quiet, same thing, sentences in noise, see these big improvements, right? But we also see, there we go, tremendous amount of variability, all right, when it comes to these outcome measures. Both on the pre side and the post side, there's a huge variability in the pre and post speech recognition abilities of cochlear implant patients. And we also have data, right, that talks about the improvement. So we know that if you look at overall in the literature, the average patient goes from very low in words, sentences, and quiet noise, and shows, these big improvements over time. But the real question is, what does this tell you about that patient's, real world ability and how this is going to affect them? And what does it tell you even about the individual patient, right? Because these are talking about averages. These are the average amount, and these are standard error here, but this is the how the average person does. So can you use these data to really tell a patient who's seeing you in clinic how they're going to do with their cochlear implant? But you can break it down even further, right? These are data from our center looking at individual outcomes. So here's word recognition scores, preoperative scores on the x-axis, postoperative scores. And you can see this is the 95% confidence interval here. And we know that 85% of patients show improvement beyond the confidence interval from their pre-testing. About 15% end up in that no particular real improvement or worsening of their score, and there are very few patients do substantially worse with their cochlear implant than they did with their hearing aid. But the question is, what does this really tell us regarding that patient's real world functional ability, right? Does improvement here portray real world functional ability? And once again, how can you use these data to really counsel a patient about how they're going to do? And one thing we have shown in our lab and others is that really speech recognition testing does not correlate with patients' real-world self-reported communication abilities. So looking at patients is across 30 centers in the United States, looking at is jumping a little bit ahead to our CIQOL outcomes, right? But here's the CIQOL scores on the y-axis, x-axis, CNC scores, and AZ Bio plus 10. We know that there's very low levels of correlation between how someone does in the audio booth with their cochlear implant in place and how kind of what their self-reported communications abilities are. In fact, if we look at overall data from our meta-analyses and other centers, we know that speech recognition ability only accounts somewhere between 4 and 16% of the variance in patients' self-reported communication ability. And if we kind of do kind of fancy multivariable regression analyses, we know that that kind of relationship is even weaker when you include things like socioeconomic status, level of education, age, things like that. Speech recognition ability accounts for even lower levels of that variance. So we know that speech recognition ability has very low ecological validity, right? Also, we know by kind of focusing solely on speech recognition testing, we ignore all the other changes that happen due to cochlear implantation. That improvement in social engagement, improving emotional state, decreased listening effort, right? So by kind of focusing solely on speech recognition testing, we ignore all these other impacts that cochlear implantation has on people's lives. So we come back to this question, right? So speech recognition testing doesn't really tell us a whole heck of a lot about kind of how we can counsel patients, kind of what can we use, right? And that leads us really to these patient-reported outcome measures, right? So patient-reported outcome measures, these are instruments that capture a patient's perspective about their overall health or treatment. These are direct assessments of how the disease or an intervention is impacting their real world, their abilities in real world settings, right? So moving beyond the booth into the real world. And importantly, kind of a lot of times PROMs are conflated with kind of quality of life improvements. And not all PROMs measure quality of life. A lot of them kind of are self-reported functional abilities, and they kind of fall under this kind of global construct of improving quality of life. But it's kind of important, I think, to separate the two. And in our field, we're really guilty of this, of kind of using instruments, right, like the SSQ or something like that, and just calling that quality of life just because it's a patient-reported outcome measure, because those two things are not the same. It's really important to know kind of what your instrument is actually measuring before you kind of consider it a quality of life instrument. Patient-reported outcome measures are also important because, once again, this is an independent assessment of the patient's condition. It removes any bias that the clinician has about how they think that person is doing. It can also efficiently measure multiple constructs at the same time. And also from a real world regulatory standpoint, so PROMs are now required to be included in any trial where where investigators are seeking approval by the FDA for a intervention. And it's also part of the Centers for Medicare and Medicaid Services Meaningful Measures framework. And so that is kind of what the CMS identifies as kind of the most important outcome measures, and ultimately these are going to be tied to kind of things like reimbursement. So there's some real world implications to this as well. But we know that PROMs are underutilized in cochlear implant outcomes. So they're about 25% of cochlear implant centers use PROMs on a routine basis. I'm hopeful that this has increased in the recent future. This is kind of about 4-year data from 4 years ago. But we also know that kind of when looking at hearing research studies in general, PROMs are kind of only used in about 9% of all of these studies. So PROMs are clearly considered a second-tier instrument to measure cochlear implant outcomes. And this is a quote that I really like from Mitch Resnick's a PhD education researcher at MIT. And I kind of adapted it for our purposes, but it's kind of, are we valuing what we measure over measuring what actual patients value, right? So we focus years and years of research kind of really solely on speech recognition outcomes, when maybe we kind of need to broaden our outcome measure basket. So why are PROMs not used more? So here's kind of results from a meta-analysis. And one of the main barriers we face is kind of interpreting what these outcome measures actually mean. So kind of if you look at these data, right, this is improvement after surgery versus getting worse. And this is a huge effect size, right, when you're looking at a meta-analysis. And you kind of look at these individual studies, about 15 here, and NCIQ, SSQ, you can see the same story, right? Mean scores were lower, post scores, the mean scores before implantation were lower. They got higher after surgery, but it's the same kind of problem we have with the speech recognition thing, right? So what does that actually mean for that individual patient? And how do you interpret what a score means, right? From going from a 37 to a 66. What does that actually mean? And this is, the main barrier that kind of not just our work, but all PROMs face is kind of how do you actually kind of interpret what the score means? And rather, not even just the mean score for a group of patients, but for that individual patient, how can we improve that? And so that's kind of the work kind of we've been focusing on with our since the development of our cochlear implant quality of life instruments. All right, so kind of at this point, I'm going to take you through because the development has a major role to play in how kind of the interpretation really is so much better with kind of instruments that are developed using a certain line of development. So it's kind of a little bit boring, but we'll take a step back and kind of go over the development because it plays a role in everything, the kind of how these things are clinically implemented. So the CIQOL instruments were all developed using rigorous development standards established by the FDA, PROMIS, which is now called Health Measures, and COSMIN, which is a European organization who kind of developed some standards for how PROMs should be developed. And importantly, kind of no previous PROM has been validated in hearing loss or CI users that kind of meets these current standards. I put this here because I always forget to mention the QR code in the bottom left corner and our research website. So a lot more detail for all of these studies can be found in the papers that are linked to on our website. All these instruments can be downloaded for free from our research website. So please, it's kind of in the bottom for a lot of these slides. So it's available there. Importantly, the development of our instruments were all used a mixed method research design. So it started off with kind of qualitative methods. This kind of started with cochlear implant user focus groups that kind of included the range of different hearing configurations of, bimodal, bilateral, hybrid, unilateral, no CI, kind of the full gambit, and a full range of kind of speech recognition outcomes for those patients as well. That then led to focus interviews, and that was kind of going over the individual items to make sure they were clear and important to adult cochlear implant users. The important thing here is that this work really established the face and content validity of our work. So we knew kind of from this starting point that all the work we were doing was kind of done and done within a meaningful kind of patient-centered framework. So what we were kind of testing and what we were measuring, we really knew was important to actual cochlear implant users. Then after that point, we move over to the psychometric analyses. This started with confirmatory factor analyses. This kind of it basically ensured that the constructs that we're measuring represented unidimensional constructs, so each one was only measuring one individual construct. And then the item response theory, which I'll talk about in a minute, but this is pretty robust modeling, so it required a large group of cochlear implant users, 371 users that were recruited from 30 centers, which are listed here, and can't thank these centers enough for helping enroll patients into this study and to complete this work and continue to be incredibly instrumental in the success of the program. So after you have you use the focus groups and the cognitive interviews to develop your item pool. These are 101 items in 7 different domains. And this is kind of your big pool of items, and you kind of need to figure out which ones you're going to use. So the first thing you do is psychometric testing to kind of whittle down the items that kind of don't fit your measurement model and that don't have good measurement characteristics. So this is kind of item response theory is the modern standard for this. It has, I won't go into it deep, but kind of several advantages of our classical test theory. This is my son. He's now 10. He would kill me if he knew that he was in the presentation. But this is kind of, item response theory is kind of what's used for all of education testing at this point, for whether it's, the ENT boards or kind of any MCAT, anything like that. And this is my son came home from school with this brochure, kind of what is MAP testing, and it went through an exact kind of step-by-step understanding of what item response theory measurement is, and it was very interesting, and it was a really nice example. But it's used kind of commonly, and this is kind of nothing new that we're creating for this. So the classical test theory is what's previously been used, and the major difference is that the classical test theory looks at the overall test itself and the psychometrics of the test, There are many barriers of kind of interpretation with these scores. Most importantly, the scores that are that result from this are ordinal, right? So there's kind of an order to kind of this score is better than this score, but there's no inherent meaning in what kind of an improvement means from kind of a 30 to a 40. There's no inherent meaning. You just know that for that overall test that that patient improved. And this is where the IRT really differs. So the basic understanding of IRT is that you have two measurements for patients, right? Or sorry, two measurements that go involved in the measurement model. First, you have theta, which is kind of what's that individual patient's ability level. And then you have the individual item difficulty. So you measure kind of, you get an idea of how difficult each item is. And it's that interaction between your patient population and the individual item. And that interaction that kind of helps you choose the items that kind of have the best measurement capacity. The scores that result from IRT developed instruments are interval in nature, so there's a clear inherent meaning in the score that really will come to play and at the end of this talk. Kind of, so there's inherent meaning in an improvement of a particular score. And importantly, you also only include items that reliably fit the measurement model. So you eliminate items that may kind of be included in classical test theory because the whole test works. But here you're kind of getting down to the individual item and the improvement and then the measurement characteristics of each item. And again, I'll show in a minute why that's important. So what happens is you use these psychometric analyses to kind of go from your item pool to your item bank. And then this includes, it's essentially a menu of items that are the best measurement capacities that are kind of are siloed within individual domains. So you know what they're actually measuring. So then you go from the item bank and then you choose, use IRT and the confirmatory factor analysis results to select the most highly discriminative items that cover the ability continuum. And that's what we did to kind of get to our CIQOL 35 profile instrument, 35 items in 6 domains. And kind of here's an example of what this the psychometric analysis looked like, right? So here are all the items listed for the communication domain. These are the most kind of considered the most difficult items to be able to endorse, and these are the easiest items to be able to endorse. Here's kind of the results that show the difficulty. These are in logits. And here's the discrimination ability, so the ability to separate individuals and their ability levels. And here we have the actual patient population that we had. And kind of using the same logit scale, you can see that there were kind of very few cochlear implant users in our cohort that were the kind of the easiest or the kind of the lowest ability level. And then you can see that the numbers, kind of frequency increases as you get to the kind of the highest ability level. And then you can see that kind of these each individual items we have that cover the ability continuum, right? So we have more kind of items focused where there's more patients, but we're ensuring by using IRT that we're actually have the capacity to measure patients with the lowest ability level and the highest ability levels. And this starts to look like a ruler, right? So kind of here at the bottom, you see kind of the lowest measurement, kind of 0, and here you see kind of a foot, right? So we know that if you kind of how you respond to each of these individual items, where you are all in our ability level ruler, right? And once again, that'll come up again at the end of the talk. And so this is kind of what the CIQOL 35 profile looks like. Nothing really that exciting. It's 35 items. The responses go from never, rarely, sometimes, often, always. And there's 6 different domains. And these are communication, emotional, entertainment, environment, listening effort, and social. The 3 that are highlighted in yellow are done so because it really shows the importance of including patients in the instrument development process, because these are domains that really have not been previously included on patient-reported outcome measures that have been applied to cochlear implant users. So we know that not everybody will want to use a 35 item instrument. So we developed this 10 item global instrument that includes all, they're all of these items are in the 35, so you can measure, you can calculate a global score from the 35 instrument. But in a minute I'll talk about some important applications of this work. And I kind of tell people that only use the global instrument if you that's all you could possibly use. If you have a huge array of instruments you're measuring, because there's so much more information that's included in the profile instrument, and the clinical applications of that profile instrument are really, they really are so much more vast than the individual just the global instrument. So then finally, just really briefly, the validation study recruited an indepatient population of 334 participants through our consortium and compared the measurement properties to the NCIQ, because that was the most commonly used in the literature, and the HUE-3. Please feel free to the paper goes into a lot more detail, but our the CIQ-L35 was more psychometrically sound and comprehensive than legacy measures for assessing quality of life in adult cochlear implant users, and it was found to be highly reliable. And importantly, in cochlear implant users, the study showed that the HUE-3 was very poorly reliable in adult cochlear implant users. That's because 5 of the 6 items include the word hearing aids. We think that includes, causes a lot of confusion for cochlear implant users about whether their cochlear implant is considered a hearing aid or not, or if they have a hearing aid in one ear and a cochlear implant in the other ear, how do they respond to that? So, the test-retest reliability was very, very low with the HUE-3 in adult cochlear implant users. So our CIQL instruments, they've now been downloaded, and we have user agreements with about 500 users. These are centers or individuals who are interested in using these. It's been adapted and translated into Hebrew, German, French, Mandarin, and Arabic, and there's 4 additional languages that are in process. But now let's get back to our original question, right? So how can we use and interpret these scores to actually implement them to kind of make decisions about individual patients and to drive individual patient care? So this is kind of going back to why this mixed methods research approach was really very important, and how it kind of can overcome some of these common problems with patient-reported outcome measures. So first, the qualitative portion ensure that the outcomes are reported within a meaningful patient-centered framework, and the quantitative portion ensure that the scores are interval in nature. And what does this actually mean? This means that scores, CIQOL domain scores, are associated with particular response patterns, and that changes in scores are associated, they have an actual meaning. So kind of how can we clinically apply this, and how can we use this to improve the interpretation of these PROMs? Well, this is where the functional staging systems come into place. And these have been used in many healthcare settings, but never in kind of hearing or cochlear and not in cochlear implantation. So these enhance the kind of how you can interpret patient-reported outcome measure scores. They divide descriptions of patient abilities associated with scores using clinical vignettes, but importantly, they maintain the psychometrically derived hierarchy of the quantitative score. So it's kind of, you get that qualitative and quantitative understanding of a score, and you really don't lose a whole lot by doing that. So how do you actually create these functional staging systems? Well, to do so, we use the responses from the 705 cochlear implant users from 30 centers. They're all experienced cochlear implant users, had at least 12 months experience. And what we then use is the IRT analyses to define, kind of figure out how many domains, how many stages each domain should have, and kind of identify what are those abilities associated with the actual outcome scores. So if we see here, here's an example, and this is the, it's just a abbreviated version of the STEM of the easiest item that was included in the communication domain. If you look here, here's this outcome score of 0, outcome score of 100, and you can see that if someone answers never to this item, their outcome score is very low, because we know that this is kind of never being able to do the easiest item is a very, very low ability level. But you can see how those response patterns change as you go along this outcome score continuum. Whereas you can say you're always able to do the easiest item, you can say, well, because it's easy, it's associated with a large range of scores, and they're the higher end. And these kind of points, kind of where you transition from never, rarely, sometimes, often, always, these are all just psychometrically derived of where these changes were. But we can actually do this for all the items for every domain. So here are all the items for the communication domain. Here are the easiest items listed here. Here are the most difficult. Here's the most difficult item here. And you can see how these response patterns change, right? So if you say you're never able to do the most difficult item, well, you still might have a fairly high level. Your score might be still fairly high because it's such a difficult item. But contrast that with the easiest item. If you say you're always able to endorse the most difficult item, well, that's associated with a very narrow range of scores in the high end of that spectrum. So we can then use IRT analyses, and we use expert opinion to identify where these cut scores. So for the communication domain, we knew that we could reliably separate patients into 5 different cohorts. The strata is the term that's used, and you can kind of get an idea of kind of what scores are associated with each of these 5 stages. Not only that, if you look at the actual what the response patterns are kind of for each of those individual stages, you can get an idea of what the actual functional abilities are of patients who are in stage 2, stage 3, stage 4, stage 5, right? So we really get a clear meaning for what someone, if they come to your clinic, who has a stage 2 abilities, we can kind of look at the response patterns and understand what those are. So this again gets kind of to looking like a ruler. We can kind of set these cut points that are like your millimeters or your inches that kind of identify improvement or kind of different ability levels kind of along each domain's each construct. But we also have data, for 705 cochlear implant users. So we know the distribution of experienced cochlear implant users and where their ability levels fall kind of within this within the different staging systems. So doing that, we can actually get for the first time a better understanding of what the real world functional ability levels are for adult cochlear implant users. So kind of we know that very few patients are after the cochlear implant are in stage 1. And here's the clinical vignette with that: unable to have a conversation in any listening environment. We know that about 13% are in stage 2, can sometimes have conversations in quiet environments, need people to repeat themselves to understand conversations in quiet environments. About 64% are in stage 3, sometimes able to have a conversation in small groups and quiet, difficulty understanding even with lip reading in noisy environments. We know that about 20% are in stage 4, able to have a conversation in small groups and quiet, can sometimes have conversations in noisy environments without lip reading. And then only very few patients kind of are in this stage 5, which are kind of essentially normal hearing, able to have conversations in all listening environments with essentially no lip reading. And so we kind of created these clinical vignettes, and then we repeated cognitive interviews with patients to make sure that they were understandable to patients and that they were kind of each stage, kind of movement along each stage, representing a meaningful improvement in abilities. And here's also just to show one more example, the entertainment staging system. We know that about 18% are in stage 1, unable to enjoy music, unable to recognize melodies in music. About 60% are in stage 2. Hearing loss prevents them from listening to TV or radio. Music does not always sound clear and natural. And then about 23% are in stage 3, the highest, which are usually able to enjoy music. Music usually sounds clear and natural, and hearing loss does not prevent them from listening to their TV or radio. And just as a reminder, we have these for all every different domain. We have this staging system available. So, the development and the application of the staging system is a novel use of the IRT-based psychometrics, not just to use in the development process, but actually to use it to improve our real-world understanding of adult cochlear implant user outcomes. It relies on that kind of that relationship that I talked about earlier between the person ability and that item difficulty that was fundamental for development, but kind of uses that interaction and the hierarchy that was developed to develop real-world interpretations of PROM scores that are more meaningful to patients and clinicians. Not only that, these increased ability levels associated with each stage might be logical, but really provided the first evidence-based understanding of kind of the abilities that actually define high versus low cochlear implant performers, that moves beyond just higher or lower speech recognition scores, but kind of higher or lower functional abilities in the real world. So kind of back to where we started. All right, so what do we actually know about adult cochlear implant outcomes? And during the evaluation process, what can you actually tell patients? And this is kind of, we'll take through kind of how we can use this to improve our evaluation process. So our current standard, is the audio booth, and that's still there. Speech recognition scores with their patient's hearing aid in place and how the average patient does with their cochlear implant. We can still use that. But a major part of the, and this is Sandy Prentice's work, one of the most important things is kind of talking about realistic expectations with patients. right? And that was kind of in that paper, it was the most important thing beyond, speech recognition score, meeting criteria for insurance, criteria for cochlear implantation. But it was the most important thing that audiologists thought, or I'm sorry, having realistic expectation was kind of the most important thing to audiologists, to making sure that patients prior to surgery had realistic expectations. But the real, the reality is, how do you do this? So kind of currently we have to rely on these general conversations about what a patient's expectations are, how we think, how we interpret, we think they were going to do with their cochlear implant. And then we don't really have any evidence to kind of, base our experiences on, right? So every clinician might be different. So what one clinician thinks is a realistic expectation compared to another clinician could be vastly different, right? So it's really not evidence-based. So we really kind of don't have a lot of evidence to kind of carry out these expectation discussions. So this is kind of where our work came into place of developing the CIQOL expectations instrument. And we used the CIQOL framework, and we validated the instrument in a group of cochlear implant, pre-CI patients who are undergoing evaluation for a cochlear implant. And importantly, scores for the expectations instrument, and every item from the expectation instrument correlates directly with the item on the CIQOL 35 profile, right? So we can actually use patients' expectation scores and compare those to our normative data to determine whether or not patients' expectations are realistic. So the goal of this is to enhance clinicians' understanding of how patients think they're going to perform. So rather than just guessing whether a patient's expectations are realistic or not, we actually use a PROM to measure this, and actually to kind of improve patients' understanding of what likely outcomes are with cochlear implants. So this graph here, this is a reverse survival curve. On the y-axis, we have the cumulative percentage of patients, and then the CIQOL score from 0 to 100. And these are the different stages kind of marked out on this graph. So you can see as you go down, right? So 100% of patients have a score of 0 or greater. As you kind of go down the curve, you can see that number changes, right? So a score around 40, about 80% of patients have that score or higher, and kind of all the way down. So we can actually use this, right? So we can have a patient fill out the CIQOL expectations instrument. And let's say they said they thought they were going to score 70. Well, we can kind of advise them, well, that's great, and that's a very, very high bar, but only 10% of patients score at that level or higher. Compare that to kind of someone who scores right around 50, a score of 52, right? We can tell them, that's maybe a little bit more realistic of an expectation, because 40% of patients or more score at that level or higher. And once again, a reminder that we can kind of frame all of these discussions using the staging system, right? So we can go through what each of these scores mean and describe with patients what these actual distributions mean for real world abilities, right? So not just use it, say a score of 53 or a score of 70 is unachievable, but what does that score actually mean? And kind of why is this so important? And this was kind of and part of our development. If we look at patients who are undergoing cochlear implant evaluations, we know that their expectations are much, much higher than what the likely outcomes are. So here's for the communication domain. The average patient undergoing a cochlear implant evaluation in our center was right around 60, around 62, and only 19% of patients actually perform at that level or higher. Here again, these are the kind of based on our normative data. And once again, for the global instrument, right, the average patient undergoing an evaluation was right around 60. And again, only 22% of patients or a score at that level or higher. So we kind of know that patients have very, very high expectations for their cochlear implant outcomes, and kind of using this system allows you evidence to kind of create more realistic expectations. So kind of going back to our original question, right? Well, how can you actually tell patients during the cochlear implant evaluation process? So kind of we can use we can use all of this data to kind of have evidence-based pre-cochlear implant counseling. So we can use patients CIQOL score, right? We can actually put that on that same kind of reverse survival curve. So we can kind of put someone on there and say, hey, you're currently performing at this level, and this percentage of cochlear implant users perform higher than that particular level. And we'll go over that in a minute. But once again, as a reminder, we focused a lot on the communication domain, but the capacity to do this, both for kind of baseline scores and for expectations, we can do this for all different domains. So you can kind of go through patients and identify which domains are most important to them, which ones they would like to go, which scores they'd like to go over, and actually, kind of use evidence to kind of demonstrate the likelihood that they're going to, show an improvement, or whether or not their expectations are realistic or not. Once again, kind of, you can put expectations on the same curve and have these discussions kind of within that framework of our staging system. So we'll go through an example of kind of what this would be like. This is an actual patient, right? So there's an actual patient where they put those check boxes. How can you use this? How can we go from using these kind of check boxes and these random interval and the random assortment on these instruments to actually improve patient counseling? So this is that patient, right? So we looked at their baseline pre-CIQOL score. They were right around 32, and we can tell that patient. So 95% of cochlear implant users have that ability level or higher. Right, so they're kind of within the range. So that would contrast with somebody who might already be functioning kind of at the very, very high end of the spectrum. And you might say, look, that's great. You're currently performing at a 65, but only 12% of cochlear implant users perform at that level or higher. So it may be kind of a reconsideration for candidacy for that patient. And once again, we can kind of use that patient, this actual patient's expectations. So we can look at their expectation and say, well, look, that's great. We know you think you're going to perform quite high, but let's kind of talk about how realistic or not your expectations are. And then finally, once again, we can do it using the language and using the staging system. And what we've been using this at MUSC, and this is kind of, it gets especially important when kind of looking at these borderline cochlear implant candidates, and we kind of and based on that borderline on speech recognition terms. For those patients who have very, very poor hearing, 0% word recognition, 6% word recognition, that's kind of there's not a whole lot of other options. But as our candidacy broadens, and as we kind of are implanting more patients with greater residual hearing, this is kind of when we've been using these the CIQL instruments to make better decisions, right? Because say, okay, well, they're a borderline candidate for their speech recognition score, but let's look at how they're actually performing in the real world and use these kind of baseline CIQL scores. And you kind of see how they're performing and see the likelihood that they could, benefit or not. And that might differ greatly, right? We've seen a lot of patients who are borderline cochlear implant candidates, and they may have, their CIQL scores, very low, or they might be performing very high. And that kind of influences how you're going to counsel that individual patient. So kind of this in summary, kind of we started the whole process with the development of our instruments. We then kind of, using our staging system, we feel like we have established fundamental rethinking of kind of how we think about cochlear implant outcomes. We've started to kind of use these instruments to apply them clinically, and actually we feel like improve patient care, and really excited about what the future holds and what other people are going to do with these instruments. And we have a lot of exciting data coming out based on kind of what I've talked about today, and actually the clinical implementation. And out of respect to these meetings, I won't talk about those the particular results of those studies, but at the ACI meeting coming up, we're talking about establishing and applying the conditional minimal detectable change. So actually the measurement, the ability of the instruments to measure change and what is a meaningful change, and how we can actually use that and discuss how many patients actually improve after cochlear implantation and when that improvement occurs. Changes in whether or not the second one, or whether or not patients expectations change throughout the evaluation process. So do they come in with a particular expectation? Do they leave with a different expectation? So are patients' expectations actually modifiable? And then the third one here for the ACIA is kind of using the functional staging system, kind of use it to improve patient counseling, and kind of showing how we can actually use pre-CI staging data to kind of do some modeling and kind of model how patients might perform with their cochlear implant. And at the AOS meeting, we'll be talking about what is the discrepancy between patients' expectation, how they think they're going to do with their cochlear implant, and how those actual patients perform with their cochlear implant. And then this is a very exciting topic to us, is understanding what are the determinants of patient satisfaction and decisional regret with the adult cochlear implant users. Again, we're worked by Sandy Prentice and our center as well, have kind of basically identified there's a large number of patients who actually have decisional regret about proceeding with cochlear implantation, and kind of how we can use these CI/QOL tools to identify some of the reasons for that. So just end with kind of acknowledgments, and first and foremost, kind of it's taken over 900 unique research participants to accomplish kind of what we've done to date, and without them and without patients being willing to participate in research, none of that would be possible. Wonderful research team, G. Dubno, Craig Veloso, Brittany Hand. Craig Veloso and Brittany Hand are our psychometricians. And a wonderful adult cochlear implant team who are always very much on board with all the work we're doing here, and the CI/QOL Development Consortium with the sites that are listed here. Please reach out if there are any questions whatsoever. Please, I'd love to have a active discussion at this point. And please visit our research website, where all of the CI/QOL instruments are available for free to download. You have to kind of sign a user agreement. So with that, we'll end.
Great. Thank you so much, Dr. McRackan. That really amazing talk. Really appreciate it. I'm sure others have questions. I'll start with one or two of my own, and then if people can either write their question in the chat box and I can read it, or raise your hand and then you're free to ask the question yourself as well. So one of the things that I was thinking about, and you gave a really great example of how in practice here at MUSC this can be put into practice, and how it can be used with patients. And I was curious how you see the major barriers to be to using the use of these measures being more broadly accepted and incorporated into other centers. And you said, well, in the beginning, in research, these patient-reported outcome measures are some of the least popular. Maybe it requires more effort. It's not because they're not the best measures, but because it requires investment, time, resources. So, what do you see those barriers to be, and what would your recommendation be to overcome some of them?
Yeah, it's a great question. The first thing I'll point out is that they're a lot less effortful than speech recognition testing, right? So they don't require an audio booth, they don't require speech material, they don't require the time it takes to go over different lists and over time. So I'll say that first. But you're exactly right. Even at our own center, we struggle with kind of the real-time use of these instruments, and it's easy to kind of give them to patients, have them fill them out. They go in a bin, they get uploaded. We put them in our REDCap database. We look at them retrospectively. That's kind of easy to do. But, the exciting part of all this work is kind of using it in real time and using it to make decisions for individual patients. And so, where we are, we have a digital platform. We've kind of talked with some folks around the country, or kind of what are these major barriers. First and foremost is time, right? I mean, having kind of taking time out of clinic for patients to complete these it's tough, and everyone struggles with it. Having patients get their and filling it out in the waiting room, and having make sure they're getting the right instruments, also difficult. Scoring them in real time, right? Going through and make sure that someone's accurately scoring these things, that's also difficult. And then interpreting, right? Taking that score, applying that staging system, and that's another major barrier. And then monitoring change over time, right? So if a patient goes from a score of X to a score of Y, is that meaningful or not? And kind of being able to not to have like an audiologist with a table kind of stapled or taped on the side of her in her office to kind of see whether that changes improvement or not. And also kind of all the counseling we talked about, right? So what are the normative data? How does this patient compare to the normative data? These are all barriers. So we have a digital platform that we're working with our information technology group here to actually do that, and to actually make all of that incredibly easy, to make it so patients get these ahead of time, they fill them out, and then it's all input into a system that's already in place that we've developed to be able to use it kind of immediately, and to be use it real time with that patient, and actually go over the data. Not only that, actually let patients have the data before they even come in, right? And let them actually be able to play with the data using kind of an app or a web-based interface, to be able to let them kind of consider how they might do with the cochlear implant, and come in with kind of very well informed with good questions. So Yeah. Many. It's something that many, I mean, there's actually a notice of special interest through the NIH that kind of is focused on exactly that. And because it's a barrier that everyone's realized with all patient-reported outcome measures is kind of that real-world implementation is very difficult. And how do you interpret the scores?
And one other question, then I'll move on. I see someone raise their hand. I was also curious, do you see a point in the future where, given the lack of correlation between changes in speech recognition measures and changes in patient-reported outcome measures, do you see a point in time when these types of measures you're discussing might be used kind of instead, or at least adjacent to the traditional candidacy determinants for insurance coverage? Like, would you like, maybe like is the wrong word, but do you see that would be maybe a more rational way?
Yeah, you're always going to have to, I think, have some psychophysical measure, that kind of looks at you meet some certain criteria that's established by the FDA, right, or the insurance companies. But I do think that this is kind of the direction many fields are headed, is kind of focusing more on the patient-reported outcome measure. And so I think it's probably my desire would be that it's kind of a give and take, right? So maybe we decrease our speech battery a little bit and then include more nuanced discussions, kind of focus on this and things that are more meaningful. I mean, the entire idea is to change the framework from kind of this, what we've always done, to actually kind of a meaningful patient-centered framework. What do patients actually care about? What do they want to discuss? And I'll tell you, and this is maybe a little bit of I shouldn't be giving away, but in one of our talks, we kind of asked patients, right, that like, how do you want outcomes discussed? And 100% of patients preferred the staging system. Right now, second, they liked the speech recognition testing, and third was just the CI-QOL score on a 0 to 100 scale. But 100% of our patients preferred the CI-QOL staging system, and using those clinical vignettes, that was their preference, right? And discussing whether or not they should go forward with the cochlear implant. So I think it's we need to listen to patients more.
We have a question from Dr. Sandra Prentice. I'll let you say your own question here.
Hi, Teddy. Very nice talk. I love this stuff because I'm on board. We really do need to be listening to patients more than relying on a behavioral score of speech discrimination, and honestly, patients hate doing that anyways. But one of the questions that I have, so for the quality of life expectations questionnaire, do you recommend giving that like maybe after their counseling? They may be coming in and they have this expectation, but then when we talk to them, they may be like, oh, okay, so I won't be hearing perfectly in background noise. Like, what is your protocol recommendation there?
Yeah, so that's a great question. And then the question is, what do you want to do with it, right? I mean, if you want to look at it, like, how does the expectation, their preoperative expectation influence, whether or not their satisfaction? You probably want to measure after, the evaluation, or before, right before surgery or something like that, kind of where they end up with their expectations. But if you actually want to use it for counseling, having them fill it out at home before they even get there, right? And have it fill out, before they meet with you. I mean, because that's what you really want to base the actual counseling on, is kind of where are they coming in with their expectations, and how realistic are those? And then you can kind of focus your counseling on that, rather than kind of what we all choose to talk about, whether it's telephone or hearing in restaurants. Kind of use that to guide the discussion. And that's once again kind of one of the focuses of our digital platform, is kind of helping with that.
Great, thank you.
And everyone, again, feel free to raise your hand or type in the box. I was also just curious if you thought it would be useful, and I don't know if this is actually valid given how these instruments were developed, but you mentioned how you could maybe use this for counseling on these border cases where someone isn't like a rock star candidate, but look, based on our data, they might really benefit. You think like measuring these types of outcome data in patients that who have hearing loss but are traditionally non-candidates, say they're just above 20% above the threshold where they should be to qualify based on CIE, like standard criteria, do you think that might identify additional individuals who down the line, based on insurance changes or whatever, might actually be good candidates even if they don't qualify?
Yeah, I mean, I think it's always a slippery slope, right? I mean, because you don't want, I mean, someone can fake a hearing test, right? They can kind of say, oh yeah, I don't have any word recognition testing. If they're not really trying that hard, we know effort, plays a role in all of kind of how these, psychophysical measures, psychophysical measure outcomes. But the same thing, if someone could, say, oh, I can never do any of these things, right? So I think it's kind of there's a lot of nuance to it. I think it's, the fact that these aren't correlated shows me that they both have value, right? I think to me, it's almost like the speech recognition testing gets you over that initial hurdle, right? Whether you meet, the insurance criteria, whether you meet, the FDA say, okay, so in my mind, it's almost like you check that box. And then I take those scores and I just put them away. I'm like, all right, that's great. They're a candidate. Now let's actually look at the CIQOL scores and let's actually see kind of let's base our discussion on that and whether or not, what the potential benefit they could get from their cochlear implant. Right. So I think I think it might ultimately identify patients kind of in the general public who could fill out CIQOL and say, wow, and you could say this is you're performing at this level. This is kind of on the low end, and cochlear implant users perform better than that. So that might kind of get patients kind of in the door and considering cochlear implantation where they may not have. So we have kind of some research kind of looking in that space as well. But I think it's it'll be interesting to see kind of how it all plays out. But once again, FDA requires these things. CMS requires these things. So I think the regulatory part might dictate it, and whether or not we want to use these things, they're coming. I mean, these are real changes that are coming, and I wouldn't be shocked for it to be included in some, of a new implant coming out to have a patient-reported outcome measure score of at least X, to be needed to be a candidate. And I think but what's great about that is that it's like, great. So that opens the door. So now we have to use it. So like, why not do something with it, right? Rather than say, okay, great, they checked that box. Like, let's actually use it to use the, to do the counseling, to monitor their change over time. And that's the work we've also done is going to show how these are really beneficial to follow patients over time, going from pre to post, following patients, actually using their scores and their stages to determine what actually people that have downloaded the instrument almost probably the most are speech language pathologists who are using this to kind of determine what speech therapy they provide patients. So they use where they are on the staging system and kind of using the that kind of high item hierarchy and how patients are responding to that. You can actually kind of say, well, this is where this patient needs the most help. We don't need to challenge them yet with kind of this, 5 people in a restaurant. Let's back up a little bit. They're struggling in this environment, so let's focus our therapy there. So I mean, I think if we're going to be kind of required to use these, let's kind of use them well. Thanks, Yvette. Yvette's done a wonderful, wonderful work in the pediatric, in this space for pediatrics. So she's done amazing work. So shout out to Yvette.
All right, well, if there are no other questions, it's about 6 o'clock. Thank you so much, Dr. McRackan, for talking, for everyone for signing in. This lecture will be posted and available on the YouTube channel, and you have the barcodes and things that you can scan even from the recording as well if you want to learn more about Dr. McRackan's work. So hope everyone has a wonderful evening, and thanks very much for being with us.
Eddie, can you show me the IRA picture, school picture?
Oh no! I'm sorry. That was only for people who were here on time.
I was dealing with an app issue with a Android phone that I know nothing about, and a Resound hearing aid, and a cochlear implant.
Ah, fun stuff.
You know.
There you go. There's